team. We are about to kick off the Best Practices web conference, Cracking the Code, Are Your Doctors Ready for ICD-10? So we're going to start here in about 2 minutes. So this is a 2-minute warning. You are on the right call. And get your notes and everything ready, and we'll kick off here in just a minute. Hey guys, good evening. Welcome to the OptiPort Best Practices web conference series. Thank you all for joining us this evening. We appreciate you getting involved, and as you guys know, OptiPort is about sharing information and all helping our eye care practices perform better, and this is a great way for our community to get together and talk about the upcoming changes related to ICD-10 and how we are all trying to best prepare for that. So we are really excited, and Dr. Rumpakis, Dr. John Rumpakis, who has been helping our OptiPort community through this change to ICD-10, is going to be our keynote speaker here this evening. He has also been involved in a prior web conference and at our Managing Managed Care conference in Chicago a few weeks back. So many of you have probably heard Dr. Rumpakis before. As you can see on the screen, he is an expert in medical coding and consulting, chief medical coding editor for the Review of Optometry and Optometric Management. So many of you have probably read some of his work prior. But if you've heard him speak before, or if you were up in Chicago for our meeting, you'll know that Dr. Rumpakis is a great speaker and keeps this topic very lively and interesting as well. So we're really excited to have him involved. And if we go to one more slide, I'm just going to quickly move so that we can pass it to Dr. Rumpakis. But one thing I did want to let you all know is in our ongoing education about preparing for ICD-10, we do have one more web conference, which will be at noon on September 2nd. And this is, the audience here would be both the doctors, like we have on tonight, as well as billers. So it will be a follow-up to some of the information that we go through today. So please mark your calendar as well for noon Central Time on September 2nd, and that will be the last of the series we put together for the ICD-10 preparation. So one last point I was going to mention is as we go through the web conference, if you have any questions or comments, you can type those in the bottom right-hand corner in the chat section, and Aaron Meyer here at OptiPort will be able to monitor those and pass those questions to Dr. Rumpakis.
And we've already had our first question, and will there be PowerPoint slides to review? The PowerPoint slides and a recording of the web conference will be on our members-only website, so look for those there.
Great. And if you are registered for the member-only website, you know how to get to that. If you don't, you can certainly contact us at aaron.meyer@optiport.com or through the OptiPort website, where you can help make sure you're registered for our members-only website. So I know I gave you a lot of info. I am going to now pass it off to Dr. Rumpakis and let you take it away and get us going on this ICD-10 info.
Great, Jim. Thank you so much. And Aaron, thanks for putting this all together, and welcome everybody. I hope that I've got some new people here, as well as people who were able to listen in on our first webinar overall that we gave. This is part 2 of 3, and it's kind of a natural evolution to the aspects of the ICD-10 and what we really need to do in our practices to be able to be ready for everything. I do just want to call attention to one thing, is if you look in your chat box, there is a link right now that's an active link. If you want to be able to go on and register for part 3, click on that, and that'll get you registered immediately for part 3. What I'd really like everybody to do for tonight is to really spend a little bit of time and just listen to things. I'd rather, if you want to take notes, that's great, but I really find that your takeaway and your ability to integrate things back into your practice are going to be much better if you just kind of sit and listen and try to put a lot of things into perspective on what you're going to do, you know, come tomorrow, next week, in the next 6 weeks as we go to implement the ICD-10. As Jim had said, the notes and the complete PowerPoint are going to be on the members-only website, as well as a recording of tonight. So you'll be able to review it and go through the notes simultaneously if you'd like to by accessing the information there. As Jim said, I do a lot of different things out in the optometric space. I have some software that we'll be using tonight to demonstrate how to convert ICD-9 to ICD-10, things like that. I do a lot of consulting, and all of the clients that I currently have as consultants or as clients are listed here. As Jim said, I am the Chief Medical Coding Editor for both Review and Optometric Management. I also write on a bi-weekly basis for Ocular Surface News, and then I do have ownership of other companies that are below the blue line in the optometric space. When we talk about the clinical cases tonight, as we go through them, the dollar and cents numbers that you're going to see, I don't like dealing in fantasy, I like dealing in reality. So what we're going to be showing you are the 2015 national average Medicare maximum allowable amounts for every single procedure. So this will be real-time data, real-time information. All policies will be current as of today. It is important to recognize that since I have many people on the line from many different states, that each and every jurisdiction throughout the country has their own sets of rules, guidelines, policies, procedures, and definitions. So it's really up to you as the individual practitioner to make sure that you're current on those prior to put everything into practice. If something's a federal rule, I will make sure that I tell you that it's a federal rule. If it's something that's a zip code specific rule, I'll try to do my best on making you aware of that as well. And then most importantly, as we go through the coding examples, remember that the coding examples are just examples. There is no such thing as a cookbook, no such thing as how are you going to be able to, do the same thing for every single patient based upon their diagnosis? Remember, we don't really ever code based upon a clinical protocol. We never really code based upon a diagnosis. And my example of that is I could have 10 people lined up in front of the room, and we could have, every single one of those people could have primary open-angle glaucoma. The exact same definition, 365.11 and a severity of mild. Yet each one of those patients would be coded differently, or could be coded differently based upon their individual history, their family history, their individual complaints, symptoms, clinical signs, individual health, medications, etc. And all of those things go into creating a code for that particular encounter. So remember that the examples are examples. They are not it's not a cookbook. You just can't say, oh, Rumpakis said to do it this way and do it this way, or he said it's this code, so do it this code. You'll see in my slides, I give examples and representations, but I'm going to challenge each and every one of you to really learn how to code the encounters overall. Tonight, what we're going to really do is talk about the genesis of the ICD-10 system, compare it to the ICD-9. We're going to learn the rules and the regulations relating to the ICD-10, how to use it in a clinical fashion, and then we're going to create a implementation plan, kind of your top 10 things that you should be doing within the next 6 weeks to really get a jump start on this. Let me say one thing before we actually get started and going through things. I really want everybody to know my opinion on the ICD-10. First of all, I think there's a lot of unwarranted fear out in the marketplace. I think there are some presenters out there that are truly trying to generate fear about the ICD-10. I've been working with the ICD-10 for nearly 5 years. And I will tell you that I think the ICD-10 is much more straightforward, much better organized, much easier to find information, makes much more common sense than the ICD-9. The only thing about the ICD-9 that it's got going for itself is that you're familiar with it. It's the only system that everybody's been using for the last 35 to 40 years. So that's why you think it's easy. But you weren't born knowing how to do the ICD-9. You learned it in school. You repeat it every single day. ICD-10 while foreign to you right now, I guarantee within 3 months, you're going to go, what was the big deal? You know, everybody's making this out to be an apocalypse. And I'm just going to tell you, I think it's going to be more like Y2K. I think you're going to wake up on October 2nd and go, wow, what happened? I'm still alive. Everything's okay. So I hope, you know, that by the end of tonight, I will have alleviated much of your anxiety, much of your fears about the ICD-10, and given to you a pragmatic method to be able to incorporate it into your practice. So our learning objectives are right here in front of us, and we'll just dive right in. The very first thing I'm going to tell you is that you are going to need to buy the books. You're going to need to have a current CPT book. You're going to need to have a current ICD-10 book, and that's the current version is the 2016 ICD-10. Even software-based systems like mine, CodeSafePlus.com, we probably have the best translation engine in the business, being able to translate an ICD-9 to an ICD-10. Even my system has its limitations. What are its limitations? I can't provide you with all of the rules and the regulations that are contained in the book. I can do the code conversion for you, no problem. I can do the correlation between an ICD-10 code and a CPT code for you, no problem. But I can't publish all of the rules because the rules are copyrighted and owned by the World Health Organization, and you're really going to need a current book to make sure you have those things as a reference. Here's my email address at the very top. If you have questions, please feel free to email me. My websites are right there. If you'd like to take a look at our software, I would really encourage you to do so. It will be a great tool for you to be able to use. And I guarantee it's going to be much better for you to use than what's being provided in your EHR. And if your EHR vendors are telling you that they're your answer to preparing for the ICD-10, maybe I'm going to have some negative surprises for you here tonight, because your EHR is not going to be your plan to integrate the ICD-10 into your practice. So very first thing is, I want you to think about medical coding. What you need to understand about the ICD-10, it's not just a system for billing. It's not just a process of creating a new code from an old code. That's not what the ICD-10 is about. The ICD-10 is a new system in creating a medical record. The easiest part about the ICD-10 is translating a code from an ICD-9 into an ICD-10 code. That's easy. Technology is going to do it for you in the blink of an eye. What your main task is going to be is being able to create a detailed enough medical record to support the highly specific ICD-10 code that you're going to be submitting for payment. What we covered in our first series of the webinar, the session number 1, was all of the compliance requirements, the legal requirements of the ICD-10, the legal requirements that you face as being a licensed physician in the United States. We talked about the U.S. False Claims Act and the penalties that you have for fabricating or fabricating diagnoses or misrepresenting information or not knowing how to code things. So if you haven't seen session number 1, I would encourage you to go back and watch that. It's only an hour. It goes by very quickly, and it does provide you with a lot of valuable information that we're going to be basing tonight's talk on. So remember, in the United States, we have to follow the Healthcare Procedural Coding System, or what's called HCPCS. There's 3 different levels of HCPCS. Those are owned by the American Medical Association. Those describe the patient-physician services, our office visits, special ophthalmic procedures, all of those sorts of things that we do with patients. The ICD system, the International Classification of Disease, is owned by the World Health Organization, and it's used worldwide, whereas the CPT or the HCPCS system is only used in the United States. There's 3 different levels of codes. The reason I call this out is because the CPT codes, the highest level, Those are the codes like fundus photograph or an office visit, those sorts of things. Each one of those codes has a very specific definition. And that definition is going to come into play to a much greater degree when we are using the ICD-10 codes, because CPT codes also have designations as far as if they're a bilateral code or a unilateral code, and then we're going to have to make sure that we're matching up the specific diagnosis with laterality specified as well. And so the things are going to have to correlate. When we get to our clinical cases, you'll see that. Let's just jump right in and talk about the ICD-9. So the ICD-9 has been around for about 35 to 40 years, as I said. It's owned by the World Health Organization, used around the world. As you know, HIPAA requires us to follow the rules and the regulations of the ICD system, both 9 and 10. HIPAA also requires you as a physician to follow all of the rules and the regulations specified by the CPT. In the ICD-9, the highest level of specificity that we can go is to 2 digits or 2 characters beyond the decimal point. Part of the problem with the ICD-9 is that it's not nearly specific enough for medicine today. And so we need to adopt a whole new coding system to be able to describe in detail what's going on with our patients. But make no mistake about it, the ICD-10 is not just about coding something. The ICD-10 is a brand new system to be able to allow federal governments, state governments, insurance carriers, and other bodies the ability to analyze diseases, prevalence of diseases, standards of care of diseases, and then be able to monetize those so that way they can pay us in a different way. Yes, the ICD-10 is nothing more than a cog in a much greater process on being able to change our payment system from a purely fee-for-service system into a quasi-socialistic medicine in a capitalistic environment system. And you'll see that as we go further. So some basic things with the ICD-9 codes. Remember that we always have to have a critical relationship between an ICD code and a CPT code. So, I couldn't have a corneal ulcer as a diagnosis and bill a fundus photograph, right? There's no correlation between that diagnosis that would support the medical necessity of that procedure. So we always have to have that kind of logical medical necessity relationship between diagnosis and procedure done. Remember that the rule is always to list a primary diagnosis code first. So if it's a refractive claim, remember that correlating the chief complaint to the diagnosis helps you establish that hierarchy of how you would submit them on your form. In the cases where you have a systemic disease, let's say like hypertension, and then you have hypertensive retinopathy with the patient, remember that the rule is that the systemic disease is always coded in the primary position and the ocular sequela is coded in the secondary position. All right, that's true also in the ICD-10. Keep in mind that you cannot, and I'm going to repeat that, cannot use the patient's symptoms as a diagnosis if you know the cause of the symptoms. So for those of you who are commonly using things like eye pain as a diagnosis, you need to know that you can't do that. You need to use the cause of the eye pain as the diagnosis. The eye pain is the chief complaint or the symptom that drove the patient into your office. If the eye pain was caused by a corneal foreign body, the diagnosis would be corneal foreign body. If you're using blurred vision as a diagnosis and the blurred vision is caused by a cataract, you're doing it inappropriately. Cataract would be the diagnosis, not blurred vision. Remember to always link the specific procedures that you're doing to a specific diagnosis on the CMS 1500 form. Remember that every linkage is absolutely critical, and that's where a lot of fraud actually happens, as well as denial of claims or carriers requesting more information or you causing a red flag with the carrier if your mapping of your procedures to your diagnoses are not accurate. In the ICD-9 system, we want to stay away from anything that has a .9 on it. Similarly, we want to do the same thing in the ICD-10. What that really means is I want to stay away from any diagnosis that has the word unspecified in it, because we don't ever want to use an unspecified diagnosis. All right. So some bottom line points. Remember that having a diagnosis that supports medical necessity of the procedure that you did is absolutely required in order for somebody to pay for it, meaning a third-party carrier. But if the only thing that you're doing is saying, hallelujah, I've got a diagnosis and a procedure and I'm just submitting them, trust me, you are never, ever going to pass an audit if those are the only two things that you have. Okay, so remember, highly specific diagnoses requires highly specific medical records. So let's go back to 2012. And what I'm going to do, yes.
Real quick, we have a question that came up. Related to eye pain, would using redness of eye due to allergic conjunctivitis be a similar case?
It depends on what's causing the redness, right? So remember that your job as a physician is to determine whatever is going on with the patient. We just don't search for a diagnosis. You're the doctor. You determine what is wrong with the patient, and then you find a diagnosis that matches what is wrong with the patient. Does that, I'm not sure who asked the question, but if that, maybe they could get back to you, Aaron, and let you know if that would satisfy them.
Yep, we'll keep you posted.
Okay, thank you. So going back to 2012 is the very first time in eye care that we got an introduction into how the thinking or the logic behind the ICD-10 actually worked. So all of you should recall that in 2012, the diagnosis of glaucoma suspect was eliminated from our diagnoses. That was no longer a valid diagnosis. What they ended up doing was saying, hey guys, just knowing that somebody's a glaucoma suspect is not enough. What we want you to do is to tell us what kind of suspect and then also ascertain the level of risk. So what we did is we now have the diagnosis of, let me go ahead here. So you'll notice here that I've got, let me change my pen style. Sorry about that. Notice that I've got, open angle with borderline findings, low risk, or I've got high risk. So I've got to be able to understand my job as a doctor is to tell the record what kind of suspect they are and then quantify the level of risk associated with that. They also introduced the concept of these staging codes, and staging codes now talk about once I have a actual diagnosis, right? So once I actually have confirmed disease over here, I now have to say what kind of, what level of severity do they have? So that's one of the very first things that I have to do now in the ICD-9 currently, and that's giving us a prelude to how the ICD-10 is going to work. Let me just shift over to my website here for a second so I can show you how things are going to work in the ICD-10, just to give you an idea of that. So what code say? Yes.
We have a follow-up from the last question. They meant if they come in complaining of redness and you find out via testing it is due to allergic conjunctivitis, do you code redness of the eye or allergic conjunctivitis as the primary diagnosis?
Oh.
Let's say they're a new patient.
Great, thank you. That makes it much more clear for me. I appreciate the follow-up. In that particular case, if a patient came in and their primary chief complaint was red eyes, you diagnosed allergic conjunctivitis, your primary diagnosis would be allergic conjunctivitis. Your secondary diagnosis could be hyperemia of the conjunctiva. So you don't necessarily have to code the hyperemia, but you certainly could. And if you did, it would be in the second position, and the cause of the redness, the chronic allergic conjunctivitis or acute conjunctivitis or GPC, whatever it may be, would be your primary. Okay, I'm just going to kind of move forward here. CodeSafe Plus is my software system. It's available for everybody to subscribe to. I'm just going to show you how those glaucoma codes are going to now look in the ICD-10. So let's say we had a patient that had primary open-angle glaucoma, and you'll see the output over here on this side. If I click on primary open-angle glaucoma and I want to convert the code, there's my ICD-10 codes, just that fast. Notice that in the ICD-10, I have a single code that describes what? Both the type of glaucoma and the stage of glaucoma using a single code. It is not a dual diagnosis like it is in the ICD-9, where I have to have one code for the type of glaucoma, another code for the stage of glaucoma. ICD-10, I have one diagnosis that tells me both. In the ICD-9, if I have a type of glaucoma that is not bilateral, let's say low tension open angle glaucoma, notice that I now have 20 different ICD-10s for me to choose from, because the ICD-10 are going to tell me what type of glaucoma, the location of the glaucoma, and the stage of the severity. And we'll show you how those codes are actually built here in just a second as we go back to our presentation. So let's talk about the ICD-10 really quickly, okay? So, you know, we kind of laughed when they were first introduced because we saw all these wacky, crazy descriptions of things, you know, like inadequate social skills, hunting rifle discharge with undetermined intent, you know, all of these crazy things. Well, realize that the ICD-10 is a much more complicated system. Note that I said it's not difficult to use. It's very easy to use. There's just more codes to choose from, and the rule sets going along with it are a little bit more demanding as the carriers and the governments, both state and federal, are requiring us to use the ICD-10s in a different way. So let's talk about the ICD-10s in particular. So every year on October 1 is the best is the anniversary date of the ICD codes. So every October 1, there's a major revision of the ICD codes. This year is the introduction of the ICD-10. There are minor revisions every single quarter. So what's going to happen is that October 1 is a major release, January 1 is a minor release, April 1, July 1, you know, are the next minor releases, and then October 1 of 2016 is the other major release. So major releases on the anniversary date of October 1, minor releases every single quarter. Remember that you're also going to need to keep your ICD-9s around, okay, for one full year, because for every claim for the date of service prior to October 1, you're still going to need to use the ICD-9 codes. So even if you submit the claim a year later, the ICD-9 codes are the ones that you're going to need to use. So the ICD-10s have been around for quite a while, 20 years in the UK. So really, United States and France and Italy, excuse me, are the two last industrialized countries that aren't using the ICD-10s. And I'll be frank with you, one of the main reasons that the United States is not using the ICD-10s is that on a global basis, we're really not a good global citizen. We have not wanted to release our morbidity and mortality data to the World Health Organization. So that's why we haven't been participating in the ICD-10. Finally, according to World Treaty, we agreed to move to the ICD-10, and the original date of inception for us was supposed to be 2011. And as you know, through the successful lobby by the American Medical Association, it has now been delayed until this year, October 1 of 2015. So the ICD-10 codes are a little bit different. We're moving from 14,000 codes in the ICD-9 to roughly 68,000 diagnosis codes in the ICD-10. But I'm going to tell you, the way that the ICD-10 is organized makes much more common sense. Diseases are organized in a way that you would think about them logically. The way we talk about injuries or trauma or how we're going to sequence things make much more common sense. And again, as we go through this, I think you'll see that to be true. The other thing that you need to know is our ICD-10 system that we're using in the United States is customized for use in the United States. We are going to have a better alliance with certain types of things, like diabetes codes are consistent with American Diabetic Association categories as examples, okay? So it's important for us to realize that. We are going to have greater specificity. I'm sure all of you have heard about this already. So how specific can we be in the eye? Well, we have to tell left eye versus right eye, upper lids versus lower lids. That's about it. We can't get a whole lot more specific than that. When it comes to injury and trauma, we do have to be a little bit more specific. We're going to have to talk about causes of injury, activities that the patient was doing while they were being injured, that sort of thing. So we're going to have to be more specific. We're going to also have to talk about different phases of treatment. So is the patient under active management? Is it a follow-up visit? Is it, what stages of this am I treating the patient? Am I treating the sequela of an earlier injury? There are some standards with the ICD-10 that really make good sense. I can look at any ICD-10 code, and just by knowing where certain numbers are, I can tell whether it's a right eye, a left eye. I can tell the level of severity. I can tell whether it's an I code or not an I code. So when I look at central corneal ulcer as an example down here, the H tells me it's an I code. The 16 tells me it's an ulceration. The 01 tells me that it's a central corneal ulcer. And the 3 tells me that it's bilateral. So when I have a 1, 2, or 3 that shows up in the 5th or 6th position, I know that that's a laterality marker. So since this is in the 6th position here, I know that that means it's a bilateral condition, okay? Injuries make much more sense. In the ICD-9 today, if a patient came into you, let's say you had a 15-year-old girl coming in and she burned her cornea with her curling iron. In the ICD-9, you would have to look that up under type of injury. You would look under burned first, then cornea, then curling iron. In the ICD-10, you're going to say what structure was affected. The cornea was affected, so I'm going to look under cornea, then I'm going to look under burn, then I'm going to look under activity, curling iron. And so that way I'll be able to actually tell logically anatomical site, then type of injury. So anatomical site first, then injury. The other thing that's so great is when we start to look at these codes, and if you look here at corneal abrasion, look at the descriptive term here, and I'll show you why that's important. I'm going to go back to CodeSafe Plus for just a second. If I go ahead and look for corneal abrasion in the ICD-9 system, and I'm going to search every ICD-9 code that has a combination of the word cornea and the word abrasion. So I'm going to look in ICD-9, and I'm going to say, show me corneal and abrasion. Gosh, I don't even have any results. You know why? Because there is no code for corneal abrasion in the ICD-9. Let me show you in the ICD-10 how well that works. I'll do the same exact type of search. Show me every code in the ICD-10 that contains the word corneal and the word abrasion. So I go ahead and type corneal and the word abrasion. And notice just that fast, right? I've got to hang up in my internet. We're actually able to determine, let's see if we could do that better. There we go, 13 codes for corneal abrasion. So just that fast, I can pick all of those things up because the description is so much easier to search. And your technology, whatever you're going to use in your practice, please make sure that you've got a great search engine in it that allows you to be able to find these things. So we do know that specificity is going to be important. And the reason that it's going to be important is because you will not get paid if you use an unspecified code. All right, carriers have already communicated that to us. Medicare has said, we have to be sure that you're not using an unspecified code. We want you to be as specific as possible. All right, and so you're not going to get paid if you're submitting things that end in a .9 or a 0 in the ICD-10. Remember, I said it's all about big data. So remember, ICD-10 is a system for healthcare systems to gather data so that they can determine the incidence of specific eye diseases, the cost for the treatment of eye disease, and the appropriateness of treatments for specific eye disease. It is a data gathering and analysis system that's going to allow the powers that be to monetize the care that we provide. If you have to use an unspecified code, please remember it should be the exception and not the rule. It is inappropriate to use a code that's not supported by your medical record. It is inappropriate to conduct medically unnecessary testing just to determine a more specific code. Do not use an unspecified code when you know that you can be the physician and come up with a very specific code of what's going on with the patient. So we do know that it's going to be different, right? I mean, the whole system is going to be a little bit different than what you're used to. An ICD-10 code is 3 to 7 characters long rather than 5. It has an alphanumeric composition. So I do want to share with you, though, we're going to get pretty good correlation. So if you're using a good conversion engine, like I was showing you in CodeSafe Plus, you are going to be able to correlate things very, very easily. If I just wanted to go ahead and say, great, let's look up 367.1, myopia, let's convert the code, just that fast, there's your ICD-10 codes. So finding the code and translating it is not going to be where the challenge is, right? And you're going to have a fairly high level of correlation from ICD-9 to ICD-10. The ICD-10 book is organized into chapters. The I chapter is chapter 7, and all I codes start with the letter H. So if you ever see something that is starting with the letter H, it tells you that it's a disease of the eye and ocular adnexa. Notice how we move from anterior to posterior, and the numeric values of the codes increase. So what I would do is I'd start to learn some landmarks, right? I know that anything above H28 is going to be posterior to the lens. Everything in front of H25 is going to be anterior to the lens. So as I increase in numeric value, I'm moving from anterior to posterior in the eye itself. The formats of the codes are fairly similar, okay? Meaning that the general category of the disease is before the decimal point. The specificity about the disease is after the decimal point. I do want to call your attention, though, to slots number, 4, 5, and 6. Sometimes you're going to have things here that are not numbers or letters. Well, it's going to be an X. If the slot number 4, 5, or 6 is a X, that X is nothing more than what we call a placeholder. The reason is that there's not sufficient information here, but we still need to have whatever is in slot number 7 show up in slot number 7, and that's called a placeholder. So anytime you have an X to the right of the decimal point, it's a placeholder. If I have an X at the beginning of a code, it's a different category, okay? And that's what the placeholder is when it appears after the decimal point. Every ICD-10 code is built, excuse me, from left to right. And the code tells a story. So if we build this one character at a time, you'll see how we get this description of glaucoma associated with ocular trauma, severity high, left eye. So the very first tells me that this is a disease of the eye and ocular adnexa. Category 40 tells me that it's glaucoma. The very first number after the decimal point tells me the specific type of glaucoma. If I said to you earlier, if I've got a 1, 2, or 3 in the 5th or 6th slot, what does that mean? That correlates to left eye. The X is a placeholder, just taking up space So I can classify the severity of the disease in the 7th slot. So I go on an ascending scale, 1 for mild, 2 for moderate, 3 for severe. So again, this code built left to right, disease of the eye and adnexa, glaucoma, type of glaucoma, location of glaucoma, placeholder, and then severity of glaucoma. Now we do have some exclusions to this rule, and at the beginning of Chapter 7, they are listed. An exclusion is basically this. It's a disease that is not a disease of the eye and ocular adnexa, but has an effect on the eye and ocular adnexa. Things like diabetes, things like neoplasms, so like a choroidal nevus, bacterial infections, viral infections, those types of things. So when they're related to the eye, but they're not located in Chapter 7, we're going to have to become familiar with where to find these things. So for example, a bacterial infection or bacterial conjunctivitis will be located in Chapter A. Viral conjunctivitis will be in Chapter B. Malignant cancers or neoplasms will be in Chapter C. Benign neoplasms will be in D, and so on as we go through things, okay? Diabetes is a classic example of an exclusion that we're going to use rather frequently. So one of the things that you would look at is if this code does not start with the letter H, what does it tell you? It's not an I code. That means the E says this is an endocrine and nutritional or metabolic disease. What kind of endocrine or metabolic disease? We know it's diabetes. What kind of diabetes? Type 2. So I know that if I see E11, that means it's going to be type 2 diabetes 100% of the time. If I have the number 9 in this slot right here in the 4th position, it means I have type 2 diabetes without complications of any sort. No nephritic complications, no cardio complications, nothing. The very first digit after the decimal point tells me what kind of complications do I have. 3 means I've got ophthalmic complications. The additional digits after that bring me more specificity. The 2 tells me what kind of ophthalmic complications, and the 1 tells me that I've got macular edema or I don't have macular edema. So it's very important that that you start to note that your medical record dictates all these things. So when I have a code this specific, I should be able to go look into your medical record, and I should be able to see that you've noted that the patient has type 2 diabetes with mild non-proliferative diabetic retinopathy with macular edema, or a notation of no macular edema present. And that's the level of specificity that your medical record is going to need to contain. Aaron, I see that a couple of other questions have come in.
Yep, we'll take it from here. So Jordan asks, are there definitions as to what criteria classifies something as mild versus severe?
Great question. Those are actually still being developed by the American the Academy of Ophthalmology and the American Optometric Association. However, certain carriers, certain Medicare carriers are already starting to define what mild, moderate, and severe are. So you would need to pay attention to the carriers in your area and look up to see what their specific policies are with respect to that specific disease state. I think we'll have much more information on this coming within the next 6 months.
Great. Next one up, does this require us to ask if they have other systemic complications of their diabetes?
You should always be asking that, right? And when you're going to be taking a systemic history, and if you're going to be getting credit for asking a systemic history, you just don't ask questions and check the boxes. Your job as a physician is to understand what other types of complications they have. What kind of diabetes do they have? Are they insulin dependent? Are they not insulin dependent? All sorts of different things that you're going to have to add to your medical record. One of the things about the ICD-10, maybe I should say it now rather than saving it till the end, I would anticipate that you should expect a 20% drop in productivity. And the reason is not because ICD-10s are more difficult. It's because they're going to require you to write more in the medical record than you're currently writing today. It is also going to take some time to find the code. It's not difficult to find it, it's just going to take some additional time. So I hope that answers that question.
All right, next one up. What if there's a differential in stage of glaucoma, OD versus OS? Do you code each eye separately?
You would only code each eye separately if there is a laterality designation between the two eyes. So if I had a like an angle closure glaucoma or that sort of thing where I'm giving a specific definition for the right eye and for the left, I would code each one separately. If a disease is deemed to be bilateral, like primary open angle glaucoma, you always code to the worse eye. So if I had a primary open angle glaucoma mild severity in the right, primary open angle glaucoma moderate severity in the left, I always would code both eyes as being moderate.
Great. Well, that's all we have for now. Thank you.
Okay, you bet. So for any of you who are using V72 as a diagnosis, which is routine exam of the eyes, note that that's also going to change. So you're going to have two different codes, Z01 if a patient has normal findings, Z01.01 if the patient has abnormal findings. The word routine is no longer in the description, and it'll be very important for us to monitor how managed vision care companies are going to be looking at these codes, because it's my opinion, okay, opinion, not fact, that managed vision care companies will start to change their offerings to the consumer and start to change how often we can do a comprehensive exam versus a routine eye exam based upon hard data that is collected about the number of normal patients versus the number of abnormal patients in their population base. So it won't be based upon speculation or policy, it'll be based upon actual hard data that they're collecting. So, it's not going to be hard. So myopia goes from 367.1 to H52.11, 12, or 13. You're going to just have to figure out, is the patient myopic in just the right eye, just the left eye, or are they myopic bilaterally? Most often of the time, what are you going to be doing? We know that statistically, that's going to be the highest correlation. Astigmatism is generally going to be the same sort of thing. If you have regular astigmatism, you're going to be looking at, this particular, erase that. It goes to this bullet point here, bullet point number 3 for regular astigmatism bilateral. So again, not difficult, just different. Keratoconus, the same way. Notice that in the 6th position, we have a standard, right? 1, 2, or 3 for right eye, left eye bilateral. Same thing with irregular astigmatism, not difficult. Cataract, the exact same way. We move from age-related nuclear cataract, 1, 2, or 3. Right eye, left eye bilateral. Notice that we don't have a severity indicator for cataract. So however you grade your cataract in your file is how you grade it, but it wouldn't necessarily be reportable. Glaucoma, as I've shown you, can be a 1 to 20 conversion. So I'm going to have to say type of glaucoma, location of glaucoma, stage of glaucoma. That's why I've got a 1 to 20 conversion. It just means that you have to pick exactly what's going on in that particular eye based upon what your medical record is demonstrating. Okay, and again, diabetes, as we talked about, is pretty straightforward in how we code it. When you have a diabetic, and if they're E09, drug or chemically induced diabetes, type 2 diabetes, or other specified diabetes, it is important for you to also code Z79.4 as a secondary, tertiary, or quaternary diagnosis to indicate that the patient is using insulin. So that's a little tip that you guys should keep handy on your notes. Get used to coding that. Get used to making sure that that notation is in your medical record to support that for diabetes. When we have a systemic disease, just like in the ICD-9, if I have hypertensive retinopathy with a patient, remember that I code the hypertension, the primary hypertension first, and then the hypertensive retinopathy second. So it's important for you to be able to do that. Notice that the retinopathy, right, has a laterality associated with it. I have the number 3 here in the 6th spot that talks about which eye it's going to be, right eye, left eye, or bilateral. So again, making sure that our CPT codes that we're using are going to correlate with the location of the actual disease itself. Aaron, I see we have one more question that popped in.
Yeah, so why do they have a code for unspecified eye?
I will, so the reason that they have a code still for unspecified conditions is that you may run into a situation where you have very little information. You may be diagnosing something over the telephone. You may be doing telemedicine. You may not have that information in your medical record. It's going to be definitely the exception rather than the rule. So it is still included in the code set, but it is rarely going to be used.
Great, thank you.
You bet. Chapter 19, this is going to be where our injuries are located. So injury and trauma are located in Chapter 19. Remember that it's organized by anatomical site, then type of injury. So I look under cornea, then I look under abrasion. I look under cornea, I look under foreign body, right? I look at the anatomy first and then the injury. The 7th character in our injury categories tells us, is the patient under active management or the initial visit, subsequent or follow-up care, or are we treating a sequela of the disease? So the A at the very last spot indicates that the patient is still under active treatment. You may end up using A as a 7th character on more than just the first claim. All right. If the patient is still being actively managed by you, then you would use an A. If the patient is no longer being actively managed, then, and you're seeing them simply for a follow-up, then you would use the letter D. If you're treating a sequela of an injury, then you would use the letter S. And I'll show you some descriptions of this here in just a moment. If I'm dealing with corneal foreign body, in the ICD-9 system, right, what do I have? Just corneal foreign body. In the ICD-10, I have corneal foreign body, right eye, placeholder, under active management, okay, or initial encounter. Notice that the last character is the only one that changes. Everything else stays exactly the same, but now I'm going to be able to tell them what phase of treatment they're in. How are the carriers going to use this information? They're going to say for the average corneal foreign body, based upon 1 million claims that we've received, a foreign body in the right eye requires, 3 visits, 2 under active management and 2 subsequent, and the incidence of sequela is very low. So they'll be able to analyze all of this data and use it to create a new payment system in the United States. Superficial injury of cornea, very similar here, okay? Causes of injury. So if the patient was, what caused the injury? And again, you want to have a very, very good search engine to help you with this information, because I can tell you, you're going to want to search all sorts of different things. If the patient says, look, I was playing basketball and that's what happened. I got hit by a basketball in the eye. I'd want to be able to look up, basketball, struck by basketball. What was my activity that I was doing? Was basketball. I was struck by a basketball, and that's my code that I would use for my injury. If I was, we always kind of laugh at the stuff like this, but if I was pecked by a chicken, we've heard all different things. I guess you can have pecked by a chicken. You could even have pecked by a turkey if that's what, you encountered. So again, the power of your technology is really what's going to be able to drive you to be able to code these things properly. We just have to make sure that, again, the 7th character matches up with what we used in our injury. So anytime you use an A in the injury, you use an A as the cause of injury as well as the 7th digit. Okay, so again, classify the type of injury by anatomical site, classify the injury by stage of visit, classify the cause of injury, and classify the activity the patient was performing while the injury was sustained. High-risk medications become a little bit more specific, whereas right now, if you're monitoring somebody with Plaquenil or something like that, we're only using a code that says, long-term use of high-risk medications, right? In the ICD-10, we have a much more specific code, Plaquenil use for rheumatoid arthritis. You would always report it in addition to the type of rheumatoid arthritis that they have, okay? So remember, type of disease and then also use of the medication or use of the drug. That's how we would do it for Plaquenil. So what are you going to do, right? So let's talk about your action plan. You know, if you guys haven't done anything yet and you're right at 6 weeks for implementation, I don't want you to go into a panic, okay? That's the worst thing that you could do. What I want you to do is I really want you to take a good hard look at your practice and build a practical plan that you can implement easily and get some good results from. So what I've done is try to think about how can we create a 10-step plan for the things that you need to think about. First of all, why bother spending the time at this stage of the game learning all of these weird esoteric codes? That doesn't make any sense at all. What you should be doing is spending time to learn the codes that your practice has been using. So I would go to your existing EHR or practice management system, print out the top 30 ICD-10 codes that you have already been using for the last 2 years. Organize them in descending order. The most frequent ones that you're using at the top of the list, the less frequent ones as we go down the list, okay? Then separate those into appropriate categories. We all know that your refractive codes are going to be the most frequently that you use. Myopia is going to probably be your #1 code, followed by probably presbyopia, followed by astigmatism, followed by hyperopia. Start to separate these, and then what I want you to do is whatever technology that you're using for your conversion algorithm, if you're using CodeSafe Plus, then use that and assign it to everybody in your practice. Be able to log into your system and say, hey, Jenny, you're responsible for myopia. Hey, David, you're responsible for astigmatism. Hey, Sam, I want you to work with presbyopia. And I want everybody to research it. Come back tomorrow. We're going to discuss the refractive diagnoses and what they convert to. So that way we can have some familiarity with it. I don't expect you guys to memorize these things. I don't expect it to be natural instinct at the very start. I want you to know how to use your conversion technology for at least the first 90 days until these things start to become very familiar for you. I want you to create a timetable so that way you can make sure you get your top 30 into the next 6 weeks, all right? I want to make sure that you've got everything working as smoothly as it possibly can be. You may want to develop a testing system to make sure that everybody in your practice knows how to do these things, because you're going to need to be able to spot check them at any given time to make sure that you're providing accurate information on your claims. Remember, the laws are not going to get any less lenient, okay, on you. You're still going to have to make sure that you're doing things correctly. Contact your EHR vendor. Make sure that they are ready to receive the ICD-10s. Check with them to see if you're able to practice with the ICD-10s in your current EHR system. Contact your clearinghouse. Make sure that they're equipped to communicate the ICD-10s by October 1. Call your contractors, make sure that, or your contracted carriers, make sure that both your refractive carriers and your medical carriers are ready to process your claims in ICD-10 language on October 1. Keep in mind that the ICD-10s are not going to go away, okay? Excuse me, this is a typo, my bad. That should be September 30th of 2016, okay? Because for any dates of service, for 1 year in arrears, you can bill remember, you have to use those ICD-9s for any data service prior to October 1 of 2015. And then what I would do is create a point person in your practice that's going to monitor changes, rules, regulations, organizing spot checks on your claims. A single person should be responsible for change management, right? Somebody that's going to be able to research, collect information, and disseminate it into the practice overall. Okay, any questions up to this point? We're good? Okay.
Yep, good.
One last thing I want to touch before we kind of dive into a couple of cases. What happens if you screw up? Well, there's two things that you need to know with the Medicare system. Number one, Medicare has said, and this is specific to Medicare only, that they will not withhold payment, okay, as long as you get the category of the disease correctly. And it will not withhold payment if the digits after the decimal point are incorrect. That does not mean that you can submit an unspecified code. They still want you to be as specific as possible, but they will not deny your payment, and it will not affect your quality reporting through the PQRS, the value-based modifier, or your meaningful use if that decimal, the codes after the decimal point are not exactly right. Okay, so what we want you to do is choose a valid code from the right family. That means the first 3 characters have to be from the right category of disease. The second thing that I want you to know is that Medicare is not requiring you to submit cause of injury and place of injury as of October 1. Encouraged, for sure. Required, not at this time. I do know that other carriers are going to require it. So workers' comp carriers are going to require it. So I want you to get in the habit of doing it. It's not difficult. I'd like you to make sure that you're doing it, but please don't get lax just because Medicare doesn't require something. Keep your internal standards very, very high, because not every other carrier follows Medicare's rules, and that's going to create additional exposure for you. Aaron, I see that we have 2 more questions that came in, and why don't you ask me those while I kind of go down through and choose our very first case, okay?
Sounds good. If someone comes back for a follow-up after October 1st, do we put in the new ICD-10 codes or keep the ICD-9?
No, you would want to use the ICD-10s. For any date of service after October 1, you use the ICD-10s.
Okay, and where's the best place to buy the books you referred to? Is it on the AOA, or where would you recommend for that?
My particular recommendation is buying it from either the American Medical Association. You can also go on to Amazon and buy it. I would encourage you to get the ICD-10. Let me just pull my book so I can read the exact title for you. Hold on one quick second. So what I have is the ICD 2016 ICD-10-CM, Charlie Michael code set, and it's a pretty thick book. It's about 800-900 pages, but that is the book that I would get.
All right, that's all we have for now.
Okay, great. I want to just go through a couple of cases. I understand that I'm over my hour. If those of you who have to go, I certainly understand, and I apologize for running a little long. I just didn't want to compromise the material. So I'm going to do just 1 or 2 cases, and then we're going to finish up. So if you'd like to hang with me, that's great. If you need to go, I certainly understand, but I would encourage you to download the presentation and the handout from the members only website. And again, if you don't have access to that, please register with Aaron for that, okay? So viral conjunctivitis, let's just go ahead and take a look at how that's going to look in the ICD-10. So when I'm looking at a patient, let's say I have a 23-year-old white female that comes in that has VSP and Blue Cross. The chief complaint, patient says, hey, you know, I've got a painful red, watery, light-sensitive eye, primarily my right eye. Patient currently wearing monthly disposable contact lenses, not sure of what care products that they're using. So you go through, you do your clinical case history that's appropriate, your clinical testing that's appropriate. You see a, presentation, something like this. How does that look in the ICD-9? Well, there's certain things that I want to make sure that I'm orienting you to. So this is my ICD-9 diagnosis, my date of service, my place of service, the CPT codes that I did, and then also the mapping from the procedure to the diagnosis, my charges, and then my units. Now notice that I've got a 2 over here, but I've only got an RT here. That means that I did the adenovirus test in just the right eye, but I'm billing the carrier for 2 eyes. So that's what's wrong with this particular claim. So how does this look in the ICD-10? In the ICD-10, I'm going to code my procedure, my office visit. If I did a clinical lab test in one eye, I would signify which eye that was in. I'm then going to then diagnose what kind of viral conjunctivitis that I'm dealing with. So remember, the viral conjunctivitises are not in the H chapter. They are not in chapter 7. They are in chapter B because they are an exclusion. They are another type of disease that has an ocular effect. So you're going to have to be the doctor and determine what kind of viral conjunctivitis do they have. If you don't know and you can't diagnose a specific type of viral conjunctivitis, I would encourage you to use other viral conjunctivitis rather than unspecified viral conjunctivitis, okay? So again, if you can't determine the specific type of conjunctivitis, use other rather than unspecified, all right? So if you saw the patient for a follow-up, remember my CPT coding doesn't change, neither does my diagnoses. Remember, there is not an active treatment, follow-up treatment, or a sequela when I'm dealing with a disease. Those only pertain to injuries. So again, not that much different than what you're doing in the ICD-9. It's just using a different code. All right, so pretty straightforward. I'm going to jump forward and see if we can go into corneal abrasion here. So I've got a 34-year-old Asian male that comes in, no refractive insurance, high deductible medical insurance, wears daily disposable lenses for sports and just social, thinks he scratched his right eye. So you've got an appearance, like this. So this case history is completely inadequate, by the way, for an ICD-10 case history. What else am I going to need to know? Well, if you scratched your right eye, what do you think scratched your right eye? Oh, I was playing basketball. I got hit in the face with the basketball. Great. Now I have the activity that you were doing and what caused the injury as well. So my therapy that I'm going to be doing, I'm going to show you why this is so important. Remember, if you're going to apply a bandage contact lens, and I'm using this case specifically, remember 92070 is an old code that disappeared in 2012. The new code is 92071. It is a unilateral code. I bring this to your attention for a very specific reason. When I'm coding this in the ICD-9, notice that I have superficial injury of cornea. That's my diagnosis. Not very specific, is it? Date of service, place of service, my 2 CPT codes that I did, but notice that something's wrong with this claim, right? I don't have a designator for which eye I fit the bandage contact lens on. Why is that important? Because in the ICD-10, this right eye designation of the procedure is going to have to match up with the right eye designation of the code right there. Okay, so how would I code it in the ICD-10? Injury of conj and corneal abrasion without foreign body, right eye, initial encounter. what was I doing? Right? Striking against or struck by another object, initial encounter. So the A here matches up with the A here. Activity, basketball. Place of injury, basketball court as place of occurrence of external cause. All right, so those would be the 4 ICD-10 codes that I would use as compared to a single diagnosis that I would use in the ICD-9. So again, type of injury, cause of injury, activity, and place. All of those different things need to be brought in when I'm actually coding an injury type of a clinical presentation. Okay, so again, follow-up visits, if the patient is no longer under active management, then you'd be again seeing them. Notice that the only thing that has changed, I'm not putting another bandaged contact lens on, so I just have only the office visit. It's now just a follow-up, so that changes to a D. Everything else here remains the same. No changes at all. Pretty straightforward, okay? I want to go to one other case, and that's the case of epilation. Let me see if I can get down here to trichiasis, and this will be our last case, and we'll finish things up. I've got an 85-year-old black female that comes in that has Medicare. Complaints are my glasses aren't working very well, glare, hard to drive at night. My left eye waters a lot. I rub it constantly. So in this particular situation, she's got really some nuclear sclerosis that's going on, primarily in the right eye, that's causing the decreased vision. Notice that she's hyperopic and astigmatic and presbyopic. Okay, so when I'm going to be looking at the situation, she's got some entropion as well that's causing some abrasion to that lower cornea there. I want to be able to epilate. So in this particular situation, here's how I code it, right? I mean, this is a totally messed up case. I put this in there to point out a lot of different coding things. What I'm going to focus on is the ICD-10 aspect of things. I did my exam, my refraction, my epilation, and potentially an anterior segment photo. My pointers here are all messed up in the ICD-9. Okay, so ICD-10, here's how it's actually going to be coded. My examination was going to be coded with, right? What's going to be my primary diagnosis? Age-related nuclear cataract right eye. That's the 2, okay, that designates things here, okay? I then have hyperopia bilaterally, astigmatism bilaterally, presbyopia by definition is bilateral. Notice that I also have my lower left lid. I went ahead and epilated. The E2 correlates with the trichiasis diagnosis, trichiasis without entropion, left lower lid. So again, what I'm going to have to look at is what's going on and how do I correlate my codes together, right? So everything can match appropriately here. That's the true key to the ICD-10, a very detailed medical record that's going to allow you to be able to create your very detailed diagnoses at the end of your case. So when we go into September, all right, what we're going to do is review the ICD system, histories of ICD-9, talk briefly about your game plan, how it's going, because remember at that point in time, it's going to be T-minus 30 days, basically. Just want to review your medical necessity and your chief complaint. Make sure that you know that your medical record is really the key to your success in the ICD-10. And then we're going to jump into some posterior segment clinical cases coded first in the ICD-9 and then coded secondly in the ICD-10. All right. So I want to thank you for your participation. I know that, I don't know, Jim, did you want to make a few closing comments, or Aaron?
Yeah, we will do that. Just wanted to ask Dr. Rompakis if I don't see any questions, but were there any closing questions? If you got a minute or two, I don't see any coming up, but we'll go ahead and walk through this. And if anybody has one dying last minute question, please submit that. Otherwise, first off, I wanted to say thank you, Dr. Rompakis. We really appreciate you walking through this great material this evening.
I appreciate it, Jim. The privilege is mine.
And to everyone else, thank you all for taking time out of your meeting. Hopefully you found this very helpful info. Actually, we do have, the point would be we have a question about follow-up, which is great. So the slide that Dr. Rumpakis just showed, September 2nd, please mark that as a follow-up date for the information that he mentioned. In addition, this information and presentation that Dr. Rumpakis went through will be available through the OptiPort member-only website. And if you don't know how to get there, if you just go to optiport.com and then go in the upper right-hand corner, there's a login sign, and you can log right in, or you can actually register and then be approved to get access to this presentation you went through tonight. In addition, questions between now and September 2nd, there are two ways we can get questions and answers from Dr. Rumpakis. One would be if you want to go, again, through the member-only website, there is a LinkedIn forum, a private confidential forum for only OptiPort members through the OptiPort LinkedIn page, and you can ask questions through that process, which we will then forward to Dr. Rumpakis. In addition, if you wanted to just use email, you can email us at solutions@optiport.com, and Erin will make sure she funnels those questions to Dr. Rumpakis between now and the 2nd. So thanks again for all your time, and one last point or date to put on your calendar. September 16th in Las Vegas is the OptiPort Spark Conference, the day before the Vision Expo show, and we will additionally have agenda items that do relate to last-minute preparations for ICD-10 for your company as well. So a lot coming up, obviously a big topic, and hopefully we're able to provide the information you need to best prepare your company. Thanks again for your all's time, and have a nice evening.
Thank you, everybody.